from London in the UK. The session objectives today will be to learn how Portico enables you to achieve favorable hemodynamics and patient outcome, to learn about the new Portico with the FlexNav system, and to learn the importance of looking ahead during TAVI and ensuring patients' coronary access preservation. So with any further delay, I will welcome you, Helge, to introduce the Portico FlexNav system.
Okay, thank you, Lars. And I would like to go on with my talk, Portico with the FlexNav TAVI system. We have to discuss several issues, and one of the most important issues is the valve design, which here is an intra-annular valve design. This design provides earlier valve functionality during the deployment. This may be important in order to guarantee hemodynamic stability throughout valve deployment. There is no need for rapid pacing during the whole deployment, and you always have a very gradual, controlled deployment, and this more time to assess the valve placement, to rethink whether this is the perfect position, or to start again and to find the perfect position. We have to discuss the coronary artery access. And the Portico has large open cell geometry, which minimizes the obstruction to coronary blood flow and which preserves coronary access for future interventions. These large cell diameters give you an area of close to 21 French square for the guiding catheter in case there is need for future PCI after placement of the valve. Next point is a consideration for future valve-in-valve therapy. So we are treating more and more patients, and when treating a patient who is let's say below 70 years old, there's a probability that this patient comes back one day with a degenerated valve, which then would necessitate a valve-in-valve implantation. And the intra-annular leaflet position may create a tissue tunnel by the degenerated leaflets, which are pushed up against the frame. And if the design is an intra-annular design, this does not prohibit the access to the coronary arteries. However, on the right-hand side, as you can see, there may be a problem if you have a supra-annular design with supra-annular leaflets, which are then again pushed against the stent and may make it more difficult to find the coronary access in need to access the arteries. Coming to the deliverability of the device, it is a low-profile device. It has an integrated sheath which allows to deliver the whole device with a 14 French profile, which is really tiny and gives you a lot of opportunities to treat the patients with the transfemoral access. The large cell framework of the valve stent reduces the metal mass and increases the flexibility. So even in a tortuous aorta, it is easy to deliver the system towards the native leaflet. And finally, the hydrophilic coating reduces the friction by 98%, again helping for a safe delivery stent. Here's the handle of the new FlexNav catheter, and there's one very important point on the left-hand side. There is a new stability layer which completely takes out the tension of the TAVI. And this helps to stably deploy the valve and to ensure an accurate placement. There is no diving, no jumping of the valve by means of this stability layer. The handle itself has a improved ergonomic design. Coming to the data, and here's a study overview. A couple of patients from the Portico IDE trial have been treated with a FlexNav, so the so-called FlexNav cohort. And you can see here, these are 100 patients at high risk. The STS score was around Euro score to around 5. Mean age of these patients, 85 years. 2/3 of the patients have been in New York Heart Association class 3 or 4. 60% had a diagnosis of coronary artery disease, and 40% had already previous CABG. When we now have a look on the outcome data, and here we first concentrate on the left column, then we see all-cause mortality after 30 days, excellent, 0. Disabling stroke after 30 days, 0. Acute kidney injury, 0. Life-threatening bleeding requiring transfusion, very low. Likewise, major vascular complication, very low. And all these values compare nicely to data which are available for as in the middle and on the right-hand side clearly indicated. When we have a closer look on the major vascular complications, we see that we have 7%, so 7 out of 100. But this closer look is necessary because 2 complications have not been on the TAVI delivery access site, and 1 complication occurred prior to system insertion. So the adjusted rate is even lower with 4%. The clinical outcome data, so the safety event rate at 30 days, which is a composite of all-cause mortality, disabling stroke, life-threatening bleeding requiring transfusion, acute kidney injury requiring dialysis, or major vascular complication, was very promising. 8% with the FlexNav catheter for the Portico device, compared to 1% or 9.7% for the competitors, as depicted on this image here. The need for new pacemaker implantation was 14.6%, which is a good value, and which again reflects the design of the valve, which is not interacting too much with the LVOT. The rate of moderate or greater PVL was 6.5, and for interpretation of this data, it's important to know that this cohort reflects the very early experience. So all implanters had less than 5 implants, and the real-world studies, which I will show you in a second, show that the PVL rate may be different with more experience. And this is shown on this slide, as you can see on the left upper part. In the early experience, there is a rate of around 7%, whereas this can decrease with a little bit more experience, more than 15 implants, to 2.6%, which is clearly in the range of that of the competitor devices. Very important, what we would like to achieve is a low gradient after the implantation of the valve, and as you can see here, this has been achieved. The gradient for the first 100 FlexNav Portico devices has been 6.7 millimeters of mercury, which is below that what has been described for Evolut or Sapien. And this is remarkable given the intra-annular design. So even annular design, you can yield excellent values concerning the gradient. With that, I would like to thank you, and I'm happy to discuss the results.
So Helge, I'm interested to know what strategies you use yourself to try and reduce the incidence of pacemakers, because clearly something has changed in the way that this valve's been deployed.
Reducing the pacemaker rate, of course, is very important, especially when we are treating younger patients. We really would like to have a low pacemaker rate. And for that purpose, I think it's really important to place the valve as high as possible. And this needs a very predictable way of implantation. Otherwise, you would have the risk of embolizing. And with a new system, it's much easier to really get exact the position where you would like to have the valve eventually.
So Helge, maybe you can just give us a short description. What's the difference between the delivery system and the FlexNav? What is that which is going to optimize your valve deployment?
There are 2 points. First is the integrated sheath, which helps to reduce the size of the sheath down to 14 French, which is really nice. And for the implantation itself, perhaps even more important is the stability layer, which helps to really precisely deploy the valve exactly at the point where you would like to deploy the valve. The previous system always had the tendency that the valve dives into the ventricle, so you always had to pull a little bit on the system. It was not so easy to really find the sweet spot between pulling, pushing, to really end up at the perfect sweet spot eventually. And this is completely different with a new system. The stability layer helps you to nice valve exactly at the spot where you would like to have it.
That's for sure. That was my impression. It's a much better delivery system than the old one. And also, I can just say that some of us are part of this Portico NG study. So this is a second generation transcatheter heart valve, which maybe the most important thing is that it includes an outer sealing skirt, which will probably even further reduce the rate of paravalvular leak. So after this introduction by Helge, we'll go to you, Mike. And you got a live in a box case for us to demonstrate how to use the Portico FlexNav.
Thank you to PCR and to Abbott for inviting me to take part in this symposium. So what I want to share with you is a very interesting case that we recently undertook at Bart's Heart Centre in London. By way of some background, this is the case. It was a 68-year-old man, so relatively young when you consider TAVI. But he was actually admitted with chest pain and troponin rise, left bundle branch block, and really came in as an NSTEMI. But he did have a history of shortness of breath for 3 months prior to his admission. He was a known vasculopathy. He was a smoker. He had a prior history of stroke and peripheral vascular disease with a previous angioplasty to his right femoral artery. Not surprisingly, the first investigation he underwent was angioplasty. Demonstrated really quite severe osteal disease of both the right and left coronary arteries, in keeping with his presentation with angina. But he also had an echocardiogram, which demonstrated a heavily calcified tri-leaflet aortic valve with severe aortic stenosis in the context of really poor left ventricular function. So it wouldn't surprise any of you to think that the first thing this man actually went for was open heart surgery with the view to AVR and grafts. And that happened the next day. But unfortunately, when the surgeon opened him up, they found they couldn't cross-clamp the aorta. It was so calcified. And they couldn't actually graft the right coronary artery, again, because it was so calcified. So, in fact, all he got was a couple of grafts onto the left system, and he was closed up with a view to him being treated percutaneously for his residual disease. Subsequently went for road ablation and PCI off the right coronary artery, performed by one of my colleagues, and with a very nice result. And during the SAVE admission, we considered him for TAVI to treat his aortic stenosis. This is his CT scan, which shows that he has a moderately calcified aortic valve with an Agatston score of 1700. The area was 430 with a perimeter of 73.5. Coronary heights were okay, although he just had this recent PCI to the right coronary artery. The left now obviously was protected, and being a vasculopathy, he had really quite poor peripheral vessels, heavily calcified. The right was a little bigger than the left, but even there we had a minimal diameter of 4.5 millimeters. So in considering him for percutaneous, aortic root was suitable for a 27 millimeter Portico valve. We felt the degree of calcification meant that would be a very good choice. He clearly got coronary disease, a recent PCI, so keeping access to the coronary arteries was important. And in view of the poor peripheral vascular disease, the low profile advantages of the Portico system may be a significant advantage. So that's what we selected. So this was a case that I performed with my colleague, Dr. Mick Oskor at Bart's Heart Centre recently. This is the team in our brief before the procedure. We wanted this to be a minimal case. Patient was under local anaesthetic with minimal sedation. Access was via the right femoral artery using ultrasound control. And you can see here we're very careful to ensure that we puncture a soft bit of the artery coming right in at the apex of the artery, which I believe helps to get good closure at the end. The secondary access was via the right radial artery, which we always try and use rather than a bifemoral access. So we placed a 4 French in the vessel there. We do an angiogram to confirm the position. Again, that's important in terms of getting good closure. And our strategy for closing the vessel is now routinely a single ProGlide, which is deployed straight up and down as it was designed. And I think that works very much better than trying to twist it. Very few failures. And then on closure, we add to that usually a single 8 French angioseal. And I find that gives us really good closure, particularly for these smaller delivery systems that you get with the FlexNav. So once the ProGlide is in, that is exchanged out for a 14 French sheath, which also dilates up the tract and for the FlexNav system when it's used. So in terms of deploying the Portico valve, it's, as we've already heard from Helge, a very stable system. And I personally quite like to just go to LAO 30 and look for a view where you've got the non-coronary and right coronary sinus overlying each other, as you can see there. And rather than where you see all 3 sinuses, because that's the way the valve deploys. It deploys from the major axis towards the left coronary sinus. And so, in effect, that's where you're going to get the biggest movements. You see, we've crossed the valve there. We introduce a exchange wire and a pigtail and measure the pressure gradients, as you'll see in a moment, confirming the presence of aortic stenosis. Again, gradients were not very high, but this is a patient who had poor left ventricular function. So you can see there's definitely aortic stenosis there. And then we introduce a Safari small curve wire into the left ventricle. I prefer to do this over a pigtail rather than from the amplats or right coronary that you use to cross the valve, as I think it is safer and ensures a better position in the apex of the left ventricle. And I think one of we have cut a little bit out of this video, but it is almost in real time. I think this whole procedure probably took about 15 minutes, and I think TAVI it's become much simpler, and some of the developments that we see in the FlexNav and other systems really make it a very simple procedure. So this is the balloon valvuloplasty. For this patient, we had approximately, I think, 24 millimeter annulus with a plan to put in a 27 millimeter valve, and so we chose a 22 millimeter Vax balloon. This is formed under rapid ventricular pacing, which we've done using pacing wires attached to the Safari guide wire, which in our experience, again, takes out the need for the temporary wire and gives a very reliable rapid pacing without the need for a temporary wire. And I think that, again, actually adds to the safety of this procedure. So balloon valvuloplasty was formed, single inflation, and then we take the balloon out and the sheath all in one go and introduce the AccuNav, which has been prepared for us. It's a really lovely system. It's very small. It's very hydrophilic, so you need to hold on to it with a dry swab. Otherwise, you'll slip on it. And if you remember, this patient had peripheral vascular disease with a artery down to 4.5, and despite that, and heavily calcified vessels, the system really went in with minimal resistance. And its flexibility and trackability means that it was really very straightforward to navigate this through the vascular system and around the aortic arch. It was a heavily calcified aortic arch, and there was a little bit of hold up there, but again, that was really minimal. So the valve is advanced, the Portico valve is advanced across the aortic valve, and I must say, again, I do this in LAO, then I will adjust craniocaudal to the valve, and I like to begin to deploy the valve very immediately. There's no point in doing an angiogram until you've got the first centimetre out. And as we heard, this is an incredibly stable system. It's really very unusual for anything, for it to move very much at all. And we just continually deploy it almost in a continuous fashion. So I think you can see the position of the frame of the valve there, just below the nadir of the non-coronary sinus. We're aiming for somewhere between 0 and 3 millimeters. And then we just continue to deploy in almost a continuous fashion, adjusting the craniocaudal to ensure that we can remain aligned with the bottom of the frame. And this is pretty much the standard for every one of these deployments, is that we just continue to, and until we get to the positive stop. At this point, just retracted a little bit on the valve to try and get it slightly better aligned with the native anatomy, and but we were very happy with that. And it's really, there isn't very much else to do other than to continue and deploy the whole valve. Now, sometimes we might move to RAO to have a look at it there, but on the whole, I try to keep this procedure as simple as possible, not move the image intensifier around too much. And I think from this LAO position, we're very happy with the position of the valve, and we just continue to deploy it until it is released. The pigtail we've left down, you can pull it back, obviously, but again, I think it doesn't make... and there it is deployed, and you can see it slightly adjusts its position, but the actual position of the bottom of the valve remains stable throughout the whole deployment. It's important to continue turning until you're fully released, and obviously then we soften up the edge of the valve delivery system, take out any stress before we begin to retract it back into the descending aorta. So you see just removing the guide wire a little bit. And of course, one of the things throughout the whole of this procedure, there's absolutely no hemodynamic disturbance at all, no need for rapid pacing, and the patient remains comfortable throughout the procedure. So the delivery system is withdrawn. It's important to hold on to the inline sheath to make sure that the delivery system, the front end of the delivery system, comes back and fully engages with that. To have a shoulder as you come back through the artery. So the valve's been delivered, and we're going to just reintroduce the 14 French sheath before we make our final checks and consider whether or not we need any further intervention, such as a bab for this patient. But, I must say, in my experience, it's actually quite unusual now. Less than 50% of patients will require a post-dilatation of the valve. So this is introduced into the left ventricle. Again, we can measure the pressure, which is clearly the aortic stenosis has gone. And I think importantly, we can see a really nice aortic waveform with a dicrotic notch and a good diastolic gradient, which I think tells us that we haven't got severe aortic regurgitation. Angiogram shows there is a whiff of paravalvular leak, And I guess some people might consider that something that they would dilate, but I was very happy with this result. And so we decided not to. The 14 French sheath is withdrawn and very gently tamped down with the ProGlide. I think one thing I've learned over the years is you don't have to push hard on the ProGlide. If you do, you're probably just cutting through the tissue with the sutures. So be very gentle with it. 8 French angioseal, and on the whole, with that combination, we'll get a really nice result. And then very gently on the sutures and cut, and that is the end of the procedure. We always do a final angiogram to confirm both that there's no bleeding, but also that we haven't lost the distal vessel. And you can see there it's very hard to know actually where the access point was. So that was the end of the procedure. The patient made an excellent recovery. 2 days later, he is very well positioned, and there was mild paravalvular leak, very nice gradients, and his left ventricular function had improved very significantly. So this was quite a complex patient, but fortunately a relatively simple TAVI procedure using a 27 millimeter Portico valve with a minimalist approach, and a patient who was discharged 2 days after the procedure. Of course, this was all undertaken during the time of COVID, and so I'm very grateful for the whole team and Rodney Orr, who is one of our nurses, who made the video for us. But thank you very much.
Mike, thank you very much. This was a very impressive case, a young patient which has been treated really nicely. I have a couple of questions. Perhaps we can start with a more technical one. So you did not implant a pacemaker, a venous pacemaker for the implantation of the valve. Do you always use this technique, and how do you react if there is any conduction disturbance afterwards?
Well, Helge, thank you very much for the question. I think it's an important question. We've now moved away from implanting temporary pacing wires, and the main reason is we had quite a lot of morbidity associated with them, particularly tamponade related to the pacing wire perforating the right ventricle. And I think it's now well over 2 years since we've been pacing through the Safari wire, and we've had no failures of that system. So I think it is a very safe system. It's very effective and works just as well as a temporary wire. Of course, you have to be ready to put in a temporary wire, particularly if you get heart block, and it's important not to pull the Safari wire out of the ventricle until you are sure that you have that heart block. So occasionally we'll have to place a temporary wire via the femoral vein during the case. But then at least we know it's necessary, and it saves the vast majority of patients who don't need it from having a temporary wire.
So, Mike, we used to treat quite old patients with limited life expectancy, but everyone is talking about expanding to younger patients with longer life expectancy. This patient was only 68 years of age. He had pre-existing conductus abnormality with a left bundle branch block and also known coronary artery disease. Does that influence your choice of transcatheter heart valve?
Thank you, Lars. Yeah, I think this is important. At 68, I think most of us would probably still go for surgery, particularly when associated with coronary disease. But that wasn't possible in this patient, so TAVI was the only option. And, in the past, we have tried to use valves that have the most data on durability for these younger patients. But I think we're now, with valves like the Portico, there is enough experience, and we are getting more and more data that shows that they are durable and will last hopefully for as long as any other valve. The other factors, such as maintaining access to the coronary arteries, is obviously important in a patient who we've just performed a PCI on. And again, I think, the Portico valve with its open cell design again lends itself to future coronary intervention should it be needed. So they are when you choose the valve. obviously, a major factor in this particular patient was his peripheral vascular disease in a vessel of only 4.5 millimeters. And the low-profile nature of the FlexNav system and the hydrophilic coating, I think you can see in the video, showed that how easily it passed through that vessel, which may have been a challenge for some of the other systems. And I think deliverability is also very important when you consider the technology.
So we have seen a very nice demonstration from Mike Mullen here on this, and I'm going to show you a few complex cases where you can use a Portico system. And a lot of people think that self-expanding technology is the same, and these are probably the two most common used, the Abbott system with a supra-annular position of the leaflets and the Portico system with an inter-annular position of the leaflets. But actually they're quite similar and quite different. People are talking about the radial force is lower with the Portico valve, but you can see here for the 4 Portico valve and the 3, it's very similar. Radial force may be a little bit higher for the smaller size valves with the Abbott, but lower with the larger size. But when people are talking about radial force, they actually mean the opening force. So if you look at this cartoon here, you can see this is a valve outside the body. You crimp it into the delivery system. The force is going to build up. It's sitting now at a diameter of 5 millimeter, and then it has to come out, and the force decrease until it meets the aortic annulus, and then it's anchoring. So when people are talking about radial force, they actually mean the opening force, how to overcome resistance from the calcium. With the first generation self-expanding technology, that opening force was pretty high, but it was reduced in order to make the system recapturable. Otherwise, you cannot resheath a valve inside the body. And probably the opening force is higher for the than it is for the Portico valve. And how can the opening force be higher with the Abbott valve? It's because Medtronic changed the capsule of the delivery system. It used to be a plastic capsule, but now it's heavily braided with nitinol, so it's much more stiff than it used to be. And that's why it's possible to recapture the valve inside the body. But there's a price on having a stiffer capsule. It's going to be less flexible. And this is just a standard case with the Abbott valve. And you all know that this capsule is never going to kink. It will maybe make a small bend, but it won't kink. So you have to be very careful in tortuous anatomy not to have a severe vascular complication when you use systems with a stiff capsule. It's not as forgiving as your other systems with flexible capsules. And this a few years back, I didn't look carefully on the CT scan prior to the procedure, didn't see this Gothic arch with acute angulation. Luckily, the patient was treated under local anesthesia, and the patient complained about sharp pain in the back as I tried to advance the delivery system around the aortic arch, and I pulled the pigtail back and could see that I actually caused a perforation. Luckily, with the same team doing the TAVI procedure as doing the TAVI procedure, so we could quickly measure the size of the aortic arch and put in a TAVI graft, which probably saved this patient's life. But of course, he was still left with a severe aortic stenosis and what to do next. So we changed the strategy from an Abbott valve to a Portico valve. And you see how nicely this Portico valve is going through this stent graft, which has been sitting in there for a few minutes. So that's the benefit of having a capsule, a delivery system, a valve with a smaller opening force, is that it's going to be fit into a capsule which is much more flexible, and you can handle these kind of anatomies. And also, despite that lower opening force, it still works in patients with severe calcified aortic valves. Look at this patient with severe calcification of the aortic annulus, a lot of mitral annulus calcification. And I think most people will appreciate this was a patient with a high risk of severe, significant paravalvular leak after a TAVI procedure. But the way you actually compensate for lower opening force is that you more frequently do a pre-dilatation to soften up the aortic annulus. So you see, after balloon dilatation, even a calcified annulus, like in this patient, can be treated very well with a Portico valve with only a trace paravalvular leak afterwards. So this is the very beautiful thing about having a lower opening force, that you have a much more flexible system and you can compensate by do more pre-dilatation if you have patients with severe aortic calcification. Another benefit of a flexible system is that you can actually get coaxial aligned even in really challenging anatomy. This patient have extreme horizontal aorta, and if you have, again, a stiff delivery system, you can try to go as high as possible on the non-coronary side, but you need to accept what you actually get on the left coronary side because you can't really get it coaxial. But since the delivery system is flexible, you can use this technique that one operator, the first operator, is pushing the delivery system to the patient, and the second one is pushing on the guide wire. And thereby you take the outer curve of the aorta, and you can put the valve on the side, and you get coaxial aligned. So as in this case, you get a very nice implantation here at a high position despite this horizontal aorta. Low-risk patient and patient with longer life expectancy is foreseen to be treated very soon. And in these patients, it's going to be very important to have a good hemodynamic outcome and a low rate of valve failure. We know the data from the two low-risk trials with the partner 3 with the SAPIEN platform and the Evolut low-risk with the Evolut platform. And what we saw is that if you treat the patient with a balloon expandable valve, you actually get inferior hemodynamics compared to surgery. These valves is going to provide a lower opening area and gradient. But if you use a self-expanding technology, as with the Evolut, you get a larger area and a lower gradient than you do with a surgical valve. And most of us believe this was due to not only the self-expanding technology, but also the supraannular position of the leaflets. But we now see data from the Portico IDE study in the US, randomizing patients to Portico against Evolut or SAPIEN 3. And you can see here on the right-hand side, the Portico again provide a larger opening area and a lower gradient than the SAPIEN valve. And on the left side, you see, maybe surprisingly to most of us, that Portico actually have the same opening area and the same mean gradient as for the Evolut platform. So it doesn't really depend on a supraannular position of the leaflet. It's just if you use a self-expanding technology, you're going to have the same high rate, benefit. And that's probably going to reflect into durability of these valves, how good your initial hemodynamic is. And maybe durability is not a big issue today because most of the patients we used to treat is around 80 years of age. And if you expect the patient to be 85 years, he's only have 5 years of life expectancy. And even though we don't know the durability of these valves, but just assume they're going to last for 10 years. So durability is not an issue because the valve is going to survive the patients. But if you're going to do putting these biprosthetic valve into younger and younger patients, let's say a patient who is 60 years of age, and he's going to live to his 85, he got 25 years of life expectancy. And if the valve is going to last for 10 years, you can see this patient will need several re-interventions during a lifetime. And you can say, when he's 70, you can just do a TAVI and TAVI. When he's 80, you can do a TAVI and TAVI and TAVI and so on. But it can cause issue with the coronary arteries. So you can divide all TAVI valve up in 3 groups. You can have the low stent frame with, of course, an internal position of the leaflets, or a high stent frame with either an internal position of the leaflets as for the Portico, or supraannular position of the leaflets as for the Evolut or for the Acroad valve. And we know that access to the coronary arteries can be challenging after a TAVI procedure, but most experienced operator can actually do it. But if you do a TAVI in TAVI, these leaflets from the first valve is going to be pushed aside and jailed between the 2 stent frame and create a tunnel of tissue. It's probably not going to be an issue for coronary access for the first one on the left side, but for the last one with the high stent frame and with the supraannular position of leaflet, you're going to create a tunnel of tissue from the left ventricular outflow tract through the sinus of Valsalva and into the ascending aorta. So let's assume this patient had his first TAVI when he was 60 years of age. He had his TAVI and TAVI when he was 70 years of age, looking like this, and he still got 15 years of life expectancy. What are you going to do the day the patient is going to be admitted with acute coronary syndrome? It's going to be difficult or maybe even impossible to engage these coronary arteries. So I hope this is to give you some idea about self-expanding technology and where Portico makes a difference compared to the other self-expanding technologies.
Lars, thank you very much. That was a fantastic presentation. I think I learned quite a lot from that. And one of the questions I have is, these are quite challenging anatomies, and you're putting the valve into heavily calcified aortic valves. How often do you need to reposition it in these patients, and how often do you need to use post-dilatation?
I would say we probably recapture about 1 out of 3 patients, not because we have a very poor implantation, but I think you have this option. It's very quick to do it. So if you can gain 1 or 2 millimeter high implantation, we're going to do it to try to minimize the conductions abnormality. Post-dilatation, again, we have a low threshold for post-dilatation due to PVL. So even if the patient have a mild PVL, we will do a post-dilatation. It's probably, again, 1 out of where we need to post-dilate.
Lars, you showed this very impressive case with this aortic arch, which was obviously very difficult to pass. And after stenting of the arch, you then brought forward the Portico device. This was really impressive. Which wires do you take in order to support the superior delivery system of the Portico to really get through the arch?
Our standard wire is a sapphire wire, just as Mike showed his slide in a box. Mm-hmm. And we can get away with that for at least 90% of the cases, maybe 95%. Then we have the very challenging, and then we upsize first to a Lunderquist wire, and we have a few cases where we use a backup wire. But we haven't had any ventricular perforation so far, but I'm always concerned about these very stiff wires up into the left ventricle. So sapphire wire will be our first choice.
Okay, and once you're at the aortic annulus with the system, can you perhaps describe again how you can steer the angle of the device so that you end up in the perfect position on both sides, right coronary and the left coronary side?
I can try to illustrate it with my arm. So let's say you have your delivery system like this, and you dive into the LV. You can either pull on it. If you pull, it's going to get close to the inner curve, and you're going to lose your coaxial alignment. Or you can push on the wire, and if you push a little bit on the delivery system at the same, it's going to lay on the side, and you're going to get on the outer curve of the aorta, and thereby you're going to gain coaxial alignment even in very horizontal aorta. But you need a system which can make a kink. If it can't kink, you will not be able to. What's make the difference between an Evolut platform with a stiff capsule and a Portico platform with a very flexible capsule?
Yeah, and I also think that's why, over our experience, I've felt that deploying this in an LAO, quite a steep LAO, works best, because the system tends to lie in the commissures between the non-right coronary artery, which is the major axis, and you really want to see the maximum expansion, because that's when it's going to look the worst, and I think that way you have the most control over it. If you deploy it in RAO, then it often looks a bit better, but you're not seeing it as its worst, which is what you need to see if you want to get a good deployment.
So thank you for joining us at this PCR e-course on the Portico valve, and I hope you learned that the Portico valve with the self-expanding technology makes a difference. It's a very flexible system, and now with the new FlexNav system, it's very predictable for the implantation. And you can gain access to the coronary arteries. You have low rate of PVL, and also the pacemaker rate is among the lowest with the self-expanding technology. So I want to thank you, Helge, and you, Mike, for joining me here. And I want to thank Abbott for organizing this e-course. Goodbye.